Thank you very much for all who have joined on behalf of Annuncia Medical. My name is Mark Geiger, and I am the Vice President of Sales and Marketing. And we are very excited and proud today to present this webinar. And we have Dr. Ramin Eskandari at the Medical University of South Carolina speaking, moderated by Dr. Bryn, who is a well-known name in the area of hydrocephalus and treatments for hydrocephalus. And with that, I would like to hand this off to Bryn.
Hi, everybody. Welcome. Thanks for being here. My name is Bryn Martin. As Mark said, I'm serving as Adjunct Associate Professor of Chemical and Biological Engineering at University of Idaho, and also VP of Research at Alcyon Therapeutics. And my research has been in CSF diseases, diagnostics, and therapeutics. So it's great to be joining this call. So to introduce our speaker today, it's Dr. Ramin Eskandari. He is Associate Professor of Neurosurgery at Medical University of South Carolina. He serves as Chief in the Division of Pediatric Neurosurgery. Also, he directs research at the Pediatric Brain Injury and Hydrocephalus Research Center. He serves on a number of boards and memberships, including Chief Medical Advisor to Annuncia Medical, and also he's a member of the Board of Directors of the Zucker Institute for Innovation and Commercialization. He's served in a number of capacities, one of which I thought was very impressive is within assisting Uzbekistan and their medical ministry aid in their medical surgical education. Also, he's done a number of peer-reviewed publications and book chapters, and he'll be speaking on the first multi-center clinical experience with ReFlow Mini Flusher. I want to remind everyone, importantly, enter your questions in the chat during this meeting throughout. I'm going to take note of them, and then we'll be able to go through those whenever we're finished with this presentation. So just remember to do that. So I'd like to turn it over to Dr. Eskandari.
Thank you, Bryn. I appreciate the intro. And thanks, Mark, for the opportunity. Thanks for the group that's joined. And hopefully people will sort of join in later too and be able to look at the video. First of all, my goal with this is really to be informal. So please, if there's something that we're actively talking about that you really want to ask a question, please, go ahead and let Bryn know, raise your hand, and he'll be able to stop me. Otherwise, we'll address as many of the questions as we possibly can at the end. I think one of the obvious reasons we're all here, either on this call or interested in this product and in the space, is because we've all seen in some way, shape, or form, either directly or indirectly, patients with hydrocephalus and shunt failures be a problematic recurrent. And in the first generation of ReFlow, where the idea really was from when the product was incepted to be able to open up a clogged system, moving from reactive management to proactive management was a huge step in the right direction. And, a bunch of us were sort of what we call early adopters, going into it cautiously optimistic, I think is the word I tend to use a lot. And we tended to use it in patients who had a lot of problems. So these are the patients who were repeat offenders, were coming in with lots of proximal occlusion problems, either at the level of the catheter or the valve or something early on in the system. And being able to put in something that not only could open up a clog system, but then once we started really testing out the idea of maintenance flushing, to be able to continue to have maintenance of flow, that really changed the game, for me at least. And I think a lot of my colleagues would feel the same. And when we started doing this, and when we started getting the experience of these patients not coming back, the kids who were having 2 or 3 shunt revisions in the last year or two, going on 2 years, 3 years, and not being in the hospital anymore, it started to dawn on us that this really could be a real game changer. So we followed a lot of our patients. So we were just doing pediatrics, but then people started to do this across the country. And really the idea moving from the Gen 1 to the Gen 2 was that we do need to iterate on this. And Annuncia, to their credit, were extremely responsive to multiple people's suggestions, not just mine and other surgeons in the space and researchers and people that had some good input. And they did do what we had asked them to do as a unified voice: make it smaller, don't make it lateralizing. So, left-sided, right-sided implantation, you're not going to have an issue with its directionality, and make it really an obvious difference from the valve. I think now that it's a singular piece of equipment, until we incorporate it all into one system, which would be the Holy Grail, it needs to be very obvious that it's a separate unit. And now it's no question. We've done some user tests and stuff like that, and it's very obvious that people are going to identify it. When we talk about the workflow, I think that's a huge one to talk about. Mike Mahonen mentioned on a call earlier that when he's surveyed some people that he works with, they would say things like, well, we don't, we might not want to do this because it's an added step, or it disrupts our workflow. And I think it's important to know that it is an added step. I don't think it would disrupt workflow. I know it won't change incision size, but it adds a few minutes of being able to splice this thing in and make sure you put a suture around to secure it. But when it comes to the added benefits, I think that's where we're really seeing the biggest added value. It doesn't change the flow through the system, as long as, just like anything else, as long as tubing's not kinked anywhere. The diameter is all within the same system, that our typical connectors are all the same inner diameter. So none of this really affects the path of CSF flow. It's just a matter of how can it help. And I think at some point we all need to have a level of confidence and persuasion based on either other people's data or our own data. But I do feel like everyone eventually will get to a point where they feel confident that this is going to help their patient population. Like I said, we did pediatrics. I think other people have done adults. I think this, from a standpoint of picking out your early patients to put this in, I think the IIH population is perfect, because they always have small ventricles, and you're always worried about them potentially fully occluding outside of the intermittent occlusions that might happen with collapsing around the catheter, but preventing the growth into the lumen and that cellular attachment into the lumen, I think, is a huge benefit of doing maintenance flushing. So when we started looking at things that we can do to help put this out there, get feedback, get peer review, also make sure there's data that we do feel like this is working, but we also want other people to see our data and to be able to accumulate their own data. In our hands, we started putting them into patients who we deemed to be high risk in the beginning, and Gen 1 was a good opportunity to do that. So we did all this stuff on our own. We did benchtop testing to demonstrate the opening of the system through a coffee ground in submersion with an endoscope spliced into the end, so we could watch the whole thing. So we felt like we did our own validation testing outside of what Enuncia had done. It's all because we wanted our own validation. But then once we put it into the 9 patients and we followed them over the course of the next 3 to 4 years, it was pretty obvious that those patients had a reduced rate of shunt malfunction. We put it into patients with super high protein rates. I think we had patients with like 1,300 micrograms per deciliter, 1,100, 800. And these are patients we'd never imagined putting it in a full shunt into in the past. Now, none of these patients had active blood. These were all very high proteins, anthrochromic. There was no red blood cells anymore. I think that's an important point. Somebody brought that up in a different webinar, and I think it's important to say we're not suggesting that we would ever put an active shunt into a patient who's got active blood products in their ventricle. But we all know those patients with huge ventricles, big vat, big fluid volume, the turnover rate to get that CSF clear of high proteins takes a long time. So in our experience, we feel like we have a method to decrease the proximal occlusion with maintenance flushing. And so it just makes sense to get those patients out of the hospital faster. And they're still going to have to go through the process of clearing out the protein, from physiologically, but we're at least making them be able to do that at home instead of sitting in the hospital with an EVD coming out of their head. As far as the experience with the new Mini, we've had 4 centers, I think coming on 5, hopefully potentially next week, with a little more than 20 implants. We're part of that group. Patient age range has been interesting. So, before the Mini, the youngest patient we put it in, I think, was 3 years old. In a very macrocephalic, so big headed 3-year-old with lots of real estate. But the Mini, we put in a 13-month-old a couple months back, and that was to me another sort of level set to say, hey, look, now we don't really have that limitation of putting it into babies anymore, which we had with the old one. It was too hard to push. It was too big. The profile, the footprint was too wide, and this smaller one, it really doesn't have that. I think there will be a lower age and lower size limit of patient, which we can all sort of individually figure out what that is in our own practice. But I just use the example of now, if you take a non-sterile version of the ReFlow Mini and just put it on the baby's scalp and push on it, before you talk about potentially implanting it, see if you're pushing the skull, right? See if that force that you're having to push on the thing is deflecting the skull bones. And if it's not, then to me, that's a good, safe patient to be able to put it in. We also implanted a teenager who, on the adult side, obviously people are used to having teaching the adults to take care of stuff on their own. On the peds side, we usually have mom and dad or caregivers do it. And in our experience, we can teach teenagers how to do this. We came up with a regimen to do the maintenance flushing. Again, this was not scientific really to begin with. We'd love to do the studies that demonstrate what that number looks like. Is that twice a day? Is it 3 times a day? Is it once a week? But we sort of picked twice a day because it was also important to us that they comply. And compliance, when we looked at our numbers and patients in whom had proximal occlusion after we had done the maintenance flushing, the only patient who had a proximal occlusion in the first 6 months was a patient who didn't comply 100% in the first 6 months with that flushing regimen. So there's something to it. There's something to that early phase of pro-inflammatory milieu that's created after implantation or after a revision shunt surgery. But the twice a day thing tends to work really well. Brush your teeth, flush your shunt. It was a good slogan. It keeps them doing it. Some would argue that do you really need to brush your teeth twice a day? I think that's a whole different story. But for now, this seems like a very easy way to get them to comply and remember to do it. The reason for the 5 flushes, I think somebody brought that up maybe last year. And again, we don't have a really good reason. I think a lot of us who grew up in the days of the old Hakim valves and the programming of those things, you hardly ever knew if you programmed it correctly. So in my training, we just did it 3 times and said, all right, well, one of these 3 is going to work. So just from the flushing standpoint, we just felt like doing it 5 individual times, and that counts as one flush episode. Felt like a good number that parents felt was they're actively doing something. The patients felt like they're actively doing something, and it's been a positive. We haven't had any problems with people being in too much pain or it being uncomfortable. I think kids in general that don't like their shunts touched need to have a little bit of teaching in the beginning. But almost every kid now that I have that's got this, they tell their parents, "Oh yeah, remember to flush my shunt." So it's become just a routine part of their care. These are the surgeons that have implanted the Mini thus far. We did participate in a survey that Anuncia sent out, which was great because it allowed us to address some of these questions. And again, it's good to see what different people are thinking, what their viewpoint is. I think I touched on a lot of this stuff, but as far as the main patient population right now tends to be that high risk, high revision rate population. For most people out there, we've shifted our practice a little bit, and we're basically putting it into everyone in whom you're accessing a shunt system for some form of revision where you're going to have an opportunity to implant it. We would not favor implanting it if the patient's got a distal revision necessarily, because you're not opening the head. But anything where the head is involved, we tend to be implanting at this point, so brand new shunts or revisions. But we understand that a lot of people will probably start just with their high risk patient population, and eventually maybe once they feel comfortable that there's enough data either from ours or from other people's or their own, that they might go to more patients. It definitely doesn't add a ton of time. I called it less than 5 minutes. I think honestly it's more like 50 seconds time, but of just implanting it, splicing it in, and then you just tunnel it the same way that you would put in any kind of valve system. Incision size has never changed for us. We don't make it bigger just because there's a reflow. The footprint of it doesn't change anymore with the Mini, especially. And then we talked about the flushing regimen of why we picked that. These are sort of the questions that have come up in the past. I think that as far as being able to teach patients and caregivers how to do this, we found that this was super easy to do. We do not have any problem with having caregivers do this, parents do this, responsible patients do this. And I sort of summarize this by saying, there is always a risk benefit that one should look at. And when you look at the potential risk of this, which I see as being almost zero, as long as you are pushing on the reflow itself, it's just moving fluid back and forth in a closed system. It's not flushing it through the valve. It's not creating a siphoning effect. So basically, as long as you're flushing, in an appropriate way where you're only pushing on the reflow, And the potential benefit is so high, even if the revision rates don't drop as much as our study demonstrated, even if it's 50% or 30%. That is such a massive game changer when it comes to shunts. And on top of that, that psychological benefit of the families having an active part in their care. I mean, I can't stress that enough as to how many patients actually are. The news followed a patient in our local area because it was just such a big deal for her. She was in healthcare and her son had multiple shunt revisions and then had a reflow put in. And her story of how they now see their lives and their quality of life and being able to travel. And she knows, she even said, it could malfunction tomorrow. I know that. But the psychology of not just being a passive bystander and being an active participant in the care of my kid and doing something that I believe can potentially mitigate the need for a revision, that's so huge. So we're working on figuring out ways how to actually quantify that and do an appropriate evaluation of the psychological side, much like they did in epilepsy with epilepsy surgery, knowing that even if the surgery took function away from them, if the seizure burden was lowered, it was a massive psychological benefit and quality of life increase. So we see that as a sort of an intangible part of all of this. Even if there's zero benefit from flushing, you haven't changed the rate of malfunction at all, which I know is not going to be true, but let's say it is. You've not added harm and you've added a psychological component that is really important. So from our standpoint, that's sort of how we've been justifying also being able to put it into everybody, giving them a role in their kids' care. I think we sort of touched on this as well, the ability to do something different than what's been done before. Mark had a nice quote of the typical insanity is expecting a different outcome by doing the same thing over and over again. I do feel like this is a level of a game changer when it comes to shunt technology. Even though it's not part of the valve system, it's part of the overall system. I would love to see us continue to iterate on this as a hydrocephalus community of clinicians and researchers. We would love to see this sort of thing become incorporated into a valve one day. Why have it be two pieces when it can all be one? Patients and families are now part of the treatment process. This is a huge psychological benefit. And as far as implanting, neurosurgeons and their patient selection, I think we can have a list of patients in whom we all feel like was a good starting point. And then you just go from there. You decide who is the best. You decide if you want to teach them. You decide if you want them to come into clinic and you do it, or your nurse practitioner does it, or your residents do it. I think all these are valid. I don't see there being a realistic, significant harm to any of these scenarios. So I think just as far as being able to gather more data and have more patients have this, I think is just going to be a benefit to our community. In summary, we do have multi-center data. We do have data from individual groups, empiric data, certain things like, for example, Dr. Vadavilu's evaluations with the ultrasound, and to be able to see the ReFlow working. I do think that the next generation ReFlow Mini is a better option for younger patients. I think we widen the age range and size range in whom we can implant, and I think that's just a benefit for those patients. They now can potentially go through a full life without having a revision. That's a real possibility. I think the maintenance flushing idea is easily prescribed to caregivers, potentially older patients, more mature patients. And I do want to emphasize that this is, again, one more thing in our toolkit, and we should look at this very actively and scrutinize it. But to put it in a nutshell, I think the added 5 minutes are definitely worth the benefits that we're seeing as far as the short-term outcomes go. These are some questions that came out of a different webinar that we did. The first question, am I going to get more phone calls? I think this is the opposite. You should get less. If you spend a couple extra minutes in the beginning teaching them how to do it, you should not be getting the phone calls from those patients in whom they might be intermittently malfunctioning and their catheters are sort of getting clogged and their headaches are getting worse. And then they might be coming into the ER. This should keep things flowing at a really good rate as normal interlumen openness goes. If they actuate the ReFlow, we talked about this, that you could push on it a million times. And generally speaking, if you're doing it in an appropriate way, you're not going to be able to push on it enough to be able to have any harm done. I do think the resistance added is pretty insignificant. We put in a number there, but it's just no different than having a regular open system or a regularly flowing system, because it's a total closed system. If there's high protein, so this is a good question. We don't know the answer to why the protein patients didn't malfunction. proximally. One of the theories that we have, again, we'd love to be able to test this, and we're working with our colleagues that have a bioreactor that we can test this in. But one of the ways that we hypothesize that this is working is that the protein, even though it can go through the system, it can clog the valve. We're not going to say that it's not going to potentially do that, but we do know that the protein also builds up at the edges of the holes. And so anything that potentially coats the catheter with something that's not silicone can then increase the stickiness. And so any little debris or protein coating that sticks onto the catheter and doesn't move through, we do know that there's not this fast flow of fluid through it. It's a very slow flow in a lot of patients, and at times no flow potentially, depending on the day and the position. If that's true, then what we're doing is we're disrupting the infrastructure of protein and the matrix of potential cells and anything that could increase the stickiness of the inner lumen and the holes. And I think that's where the benefit's coming from, is that if you're pumping this thing a couple times a day, you're just not allowing that slow process of adhesion of various proteins and cells and scar tissue to form inside of there. And so that disruption then just makes that process so much slower, almost like atherosclerosis in an artery. You're just not allowing that first set of plaques to form that then they can, more and more things can build on. And that's the theory that we have, and we'll hopefully be able to test that. Over drainage, this is not going to address over drainage problems. We talked about this at the last webinar, and Benny Eskandari has shown really awesome videos on this and has really good data that looking from with an endoscope, even that the ependymal walls kind of get sucked into the hole of the catheter in those patients who have very collapsed ventricles. But what this does is it opens up, it tears away the scaffolding that's forming on the inner lumen from those ependymal walls being right against the catheter. So eventually, over time, we think the reason why these patients with small ventricles can fully obstruct is because eventually those things completely block in there, and there's enough of a scar formation, and there's enough of a glial band that it can't pop back open even with a slightly higher intraluminal pressure. And so what we think is happening in these cases is that it's preventing that from happening. So it's not going to prevent over drainage. No one's promising that. But at least in patients who have that high risk in that over drainage population or that really collapsed ventricle population, it can help prevent that inner lumen scar formation and hopefully prevent a full obstruction from happening. I'm not worried at all about hydrotrauma. We've talked about this ad nauseum, and I think most neurosurgeons know that 0.4 cc's is just nothing. We inject way more than that into EVDs. We put much larger catheters through the brain, endoscopes and dilators. So if the tip is in parenchyma, you're not going to be able to flush it anyway because there's going to be no flow. But if the tip is in the ventricle, 0.4 cc's against, even if it's right up against a ventricular wall, that's not going to cause hydrotrauma to the ventricular wall. So I'm not worried about that at all. I don't think any of my colleagues have really worried about that as well. And then the financial side, in general, you look at things like, preventing one shunt revision is, just that by itself is a significant cost reduction. So paying, a few $1,000s for a product versus, tens of thousands of dollars for a hospitalization. And then you add that, because if you have multiple revisions, now your infection rate goes up, and those patients are now in the hospital for at least 2 weeks or so with catheters in the ICU and whatnot. So there's a lot of potential healthcare implications here from a cost standpoint. I do think that eventually insurance companies are going to get wind of this, or at least they should, and there probably will be some implication as to being able to get reimbursement for this directly, or at least make it almost to the point where we should be thinking about it as standard of care, or some form of it as a standard of care. So I think that's where the value analysis is going to go. And with that, I'd love to just thank everybody for being here, and definitely open to questions. And
yes, so we have some questions, and if anyone's hesitant, just type them in. And if they're really weird, then we'll just not say them, or maybe we will. We'll do random. So the first one is, how do you confirm shunt status? For example, increased flow rate after flushing?
So that's a good question. So I would say one of the things that is important to differentiate is that maintenance flushing versus not flushing and waiting until a malfunction happens and then opening it up and re-establishing flow. So if you've got a patient in whom you haven't done maintenance flushing, or you have, but they're presenting with a shunt malfunction signs and symptoms, those patients, that you don't treat them any differently. So if you've got imaging, let's say you get an MRI or you have an ultrasound or something that shows the ventricles have gotten bigger, or the patient has signs that something's wrong. To me, the first thing you would do is you'd flush the system once or 5 times or whatever you feel is appropriate. If you need to reevaluate because the patient clinically got better, because if the patient clinically didn't get better, then you're going to surgery anyway, and you've got lots of objective data on a malfunction happening. But if you see a patient improve after that, then there's a whole bunch of ways. I think you can look at, technically, you could do a shunt dye study where you're injecting tracer and you can follow it down. You can do another MRI to see if the ventricles got smaller now that there's active flow. Ultrasound, same deal. Technically, you could even do a observation period where you watch them in the hospital. I don't think there's anything active that right now we can do to watch flow other than ultrasound through the the fontanelle or the burr hole while you're doing it, which we did that in patients on Gen 1. But I think the more important thing is, do you have a way in which you can at least watch them if they're clinically better, so you don't have to necessarily jump to surgery? And so that I think is an open door. Everybody could do whatever they feel is appropriate clinically, but I think all of those are options.
So I have another kind of related question. It's with this ReFlow Mini, do you have tactile feedback to actually determine with certainty that the catheter is open, or is it that really you don't have that ability?
If you push on a reservoir of a valve and it's sluggish to refill in a patient who has very large ventricles, then you have to assume that there's some element of a partial obstruction. If it doesn't refill at all, you know that there is no movement of CSF from the ventricle into your reservoir. The same exact thing goes for reflow, because the reflow in general is basically just an added reservoir. And so if that added reservoir, you push on it to flush, you're flushing everything proximally into the ventricle. If you push on it and it doesn't refill, that's your tactile feedback that the ventricle is fully occluded, it's not coming back. Now, if you push on it and it's kind of hard to push, and we've had this happen too in patients who are chronic occluders, the mom said, in the morning when I push on it, it's a little bit harder to push. And then that second time I go to push, it's really easy. Well, I mean, that's obvious, right? She's a partially obstructed catheter. And then after that, it's a lot easier to push on it. Those are the tactile feedback you're going to get. And if it refills right away, then you do have flow through the catheter. Now, do you know how many holes are open? Or no, we don't know any of that stuff. Those would be great things to have, eventually have ways of sensing. But as far as we're concerned, if there's open flow and it's an open system now, and the patient's clinically fine, then there's really no reason why you would ever do anything different with that patient, even if they didn't have a reflow.
Okay, so next one here is the patient or caregiver compliance with flushing an issue?
I would say an issue, you could take that 2 ways. Is it challenging to get them to be compliant, or is it important that they are compliant? And I'll answer both of those. In our experience, it was not at all a challenge to have them be compliant. So there was only one patient that was not 100% compliant, and we did this through surveys and asking questions when they came back to clinic for follow-up. So from our standpoint, no, it was not a challenge, but it was important. So in the only patient that had a malfunction in the first 6 months, a proximal malfunction, even with flushing, was the patient who was only 50% compliant in the first 6 months. In the next 6 months after that, when we followed them, there were a handful of patients who were about 50 to 75% compliant, and none of them had malfunctions. Now, the numbers are low. I'm not making conclusions, but it was an interesting observation. And so from that standpoint, I think it did make a difference, and we want to make sure that we can keep our patients compliant. It seems like the first 6 months is more important.
Yeah, so another one here, it looked like the reflow was implanted in people who are typically higher risk. And the question is, why not just implant this in every hydrocephalus patient?
Yeah, I mean, I sort of talked about this in the beginning, is that we did do our first phase, I would say, of implants with the Gen 1, just because of a timing standpoint. It was up until COVID came. We did choose only high-risk patients. And what we called high risk, when we looked at the various models of high risk, we had those patients in whom had very small ventricles or had minimal CSF space around the ventricles. or those that were post-hemorrhagic hydrocephalus. And in our 9 consecutive patients that we did that with, they all happened to be post-hemorrhagic. So anyone who was post-hemorrhagic hydrocephalus or had these really small ventricles at times of malfunction were the ones that we picked. And these are patients who were having multiple revisions. But after that, for us, we felt like we have enough proof that this is potentially very beneficial and at worst slightly beneficial, and there's no harm that we can think of. So we are implanting it in everybody. And I do feel like everybody needs to go through their own version of how they want to adopt. I think a lot of us would hopefully adopt from our colleagues' experiences. You don't have to necessarily do your own study at your own center, but if enough people are coming, by and saying that this seems to be minimal workflow and interruption, cost is definitely negligible compared to revision rates or revision costs, then I don't see a reason why you shouldn't put it into everybody, honestly. I mean, the only things I can think of are physical reasons, right? Too small of a head, not enough landscape or surface area to be able to implant something in line, too compliant of a skull, too thin of a skull to be able to push on it. Those would be the physical limitations. But outside of those, I honestly can't think of a reason why you shouldn't.
We have another question. What would be the youngest age patient that could be implanted?
That's a good question. I have been asked that, and I think I can't really give an age exactly. I think it does depend on size more than age. For example, if you're doing a posterior approach on a very newborn that doesn't have a lot of space from the burr hole site down to the neck, you're not going to be able to have space to put in both the reflow and a valve in line and have it still be on the skull. So I think those are going to be important factors. So if you go up to a frontal, you could probably do that. The other one is going to be the extremely young patient. So a patient who is 34-week preemie that doesn't have active blood in their head, and you want to shunt them because their weight is big enough, but their head might still be too compliant, and their skull might just be too loose. So when you push on the actuation of the flusher, the skull is moving. So you don't necessarily want to keep moving the skull of a newborn around. So I think those are going to be the things that you assess. And my little trick that I thought of to be able to see if someone could be an implanter is you take a non-sterile version of it and you put it on their skull, on their scalp, and you push on it and you see if there's any movement. And if the skull is thick enough and hard enough, there's no movement, and you know that there's enough land surface area, then those patients can be implanted. I don't see a reason why not.
And another just practical question, how many times can the flusher be flushed, and can it be done at home, which I think you've kind of covered, but for me, I'm thinking I have little children, and I wonder, are they going to play with it and have some problem? You know what I mean? It's something that you wonder as a parent.
Sure. I think it's a great question. Because of the physics of the way it works, and that it's not siphoning fluid through the system. As soon as you push on it, it blocks distal flow. So you're really just moving fluid back and forth in a closed system. You could sit there and flush it all day long. Honestly, from a physics standpoint and a physiology standpoint, it's not going to do anything detrimental. I don't think most patients with shunts actually enjoy the process. And so even though we've had patients who just got used to it, and they tell their parents now, make sure you flush my shunt because they just got used to brushing their teeth and flushing their shunt. I don't think people are going to sit there and play with it. I don't think it's one of those sort of novelty things. A caveat to that is laying on it. Is that a problem? I think, first of all, that's been demonstrated that the amount of force needed to actually depress it is much more than someone just laying on it. However, if you got to a point where you created one that was soft enough that you could implant in younger patients, could that be an issue where they got big enough and heavy enough that the softer implant could be depressed all the way? That's a future problem. Even there, it's not going to be occluded more than a few seconds because no kid is going to lay on a hard surface directly on top of this thing for more than a few seconds anyway. But I don't think that right now with the current iteration that we have anything to worry about from that standpoint.
So another one here, can ReFlow be used with an EVD right, now at this time? So one other question here, actually, I like this question a lot, is when you press this thing, do you feel a sensation in your brain? Is it something that tickles, or what? Is there anything like that?
So I have the patients who have the competence and the wherewithal to potentially answer that question. I've asked them, and none of them say they can feel it. Now, kids are a different story, right? If you ask a 6-year-old that can answer the question, they're going to say yes to everything or no to everything. So I don't find that to be very useful information coming out of that age range. But I don't know what the answer from the adult side would be, and I would be curious if any of the adults that have had this, that do this, would feel something, just given that they might have a little bit more of a perception of what, and an awareness of what are they feeling something. If most of us neurosurgeons have had patients after a big surgery or any intracranial work that they come back and they say they feel slushing around, or they hear waves inside their head after disruption of the intracranial vault. And a lot of us tend to tell them, well, it might just be that there's some air still in there and the fluid is sort of shifting around with the air. Because this is such a low volume and it's a closed system, I don't think they're going to feel anything. The intraparenchymal space and intraventricular space don't have pain sensors or pressure sensors. It's all on the outside. It's the dura that really feels all these kind of things. So I don't think that anyone's really going to feel anything, but I don't know what the adult side would say.
Another question. In the scenario where you believe the ventricular catheter is blocked, have you been able to witness symptom resolution, actually in real time in the clinic? Or is it something that you got to wait until you get home, or like how acute is this?
Yeah, that's a really good question. So we haven't had a patient in whom we've flushed prior to that has had the implant that got blocked, and we're able to flush and see a symptom resolution. What we have done is we've had an intraoperative patient who had a shunt obstruction, of catheter obstruction, where we disconnect. This is a patient in whom we're going to implant the ReFlow anyway, but we disconnected the catheter. There was minimal to no flow. We hooked up the ReFlow that we're going to put in anyway, in line, and pressed it once after having primed it. So it's got a little fluid in it already, and pressed it. And I think we did 2 or 3 presses, and then opened it up, and there was active flow. So it did open up a already implanted catheter that was obstructed. And we saw that in real time. We actually have a video of that. It's pretty cool. We also have ultrasound evidence of reestablishment of flow, and the fact that it opens it up in an EVD set, or I'm sorry, in a shunt setting. So we don't have any symptom resolution. I do think that in the paper, in the 25 patient paper, they did have a patient who had symptom resolution at the time of pushing it. I can't remember exactly the details on that, but I think there was an adult patient that had that.
We're towards the end of our questions, so if anyone else has a question, please enter it. I have a question. So being a scientist, as I am, a CSF researcher, there really is some evidence showing that the CSF viscosity can change quite a bit, especially with protein content. And I think there's also evidence that quite a few shunt valves operate differently depending on the viscosity of the fluid. And that's a confounding factor that, when does it open? When does it close? How does it function? Right. So given different CSF viscosities, do you have evidence with this ReFlow system that it still works, that would be functional? Because as I understand with the valves out there today, there's a whole host of them. That's a big challenge because it's just nonlinear. The fluid itself makes it quite challenging. It's this unknown variable coming in, what's coming in, and how does the valve function?
It's definitely it's a good question and a good problem to bring up, because every valve that's ever been tested for what, especially programmable valves or different, variable setting valves, they've always been tested with water, right? Or artificial CSF, or something that's basically like water. The pressure of water against a valve is very different than the pressure of a syrup against a valve. And basically, if I'm not mistaken, what you're asking is that viscosity changes the dynamics of where that 3 on a Certas or 5 on a Certas will open. And we don't have evidence specifically with ReFlow patients. However, I will say that the only thing I can tell you for sure is that high of a protein in which we've implanted the 1100s, the 1300s, that CSF is definitely not clear. I mean, it's clear in the fact that it's not cloudy, but it is xanthochromic and it is definitely more viscous. When you look at it in a bag, it's got that, hazy oil water, like hallucination in the desert style feeling. And so that's a heavier component, right? That there's a difference there. And even in those patients, it's been able to keep those proximal catheters open. So I don't know exactly as far as flow goes, whether those things have been worked out, but at least we know it can work in that environment.
Good answer. That was random. These are not rehearsed. So let's see, we have another question here. Great, thank you. So you mentioned a test using coffee grounds and an endoscope. Is this described in one of the papers, or was this just an informal thing?
Yeah, so I thought about putting it in the paper, but the paper was so clinical that I kind of wanted to do a completely separate benchtop paper that looked at just benchtop testing of the ReFlow in its various forms. So I'll describe the test in a little more detail. I do have videos of this that I could send to anybody who'd like to see it. It was a very formalized test. It was informally done, as in I didn't publish it yet in a techniques kind of paper yet, but it's definitely on my list of to-dos. So what we did is we created, and with the help, I did it once by myself, and then we replicated it with a lot better video and a lot better in a more formal setting. The more formal setting was basically a closed cylindrical, CSF vault of fluid of water of saline, where there was a watertight entry port where you could put in a catheter. On the other side of the cylinder was a watertight entry port where you could put in an endoscope. And so we used a Claris endoscope that would go right up the lumen of the catheter. Now, the difference is that usually you'd put the endoscope down the lumen of the catheter towards the holes. And what we did is we cut the very, very tip of the catheter. So all the holes were still there. You could see them, but we stuck the endoscope up and coming back up at you. And that allowed us to be able to then see up the catheter if as stuff goes in, as coffee grounds were introduced into the system, it was very obvious that as soon as you allowed the catheter to flow, coffee grounds were getting pulled into the system. And because you're in the distal end, or whatever you want to call it, the tip of the catheter, you could look up and see all the holes and then see the flow out the catheter like a natural flow would go in a shunt. And then we just dropped the end of that thing down to increase flow rate. And what we noticed is that we could wait a few, 20 seconds, 30 seconds, whatever, until the coffee ground started to occlude the holes of the catheter. And then you saw the flow rate diminish. So that's how we knew that we were creating a very obstructive model. Then we just had a ReFlow hooked in line, because again, flow is going to be not limited by the ReFlow if it's not depressed. And then we pushed on the ReFlow. And because you have the endoscope, you're watching what the ReFlow does when you actuate it. And we pushed on it, I think once it opened up some of the holes, and by 3 times, all the holes were open. And then we repeated this multiple times. We repeated it with different flow rates based on how high we raised and lowered the other end. And then we also did it based on how much coffee grounds we put in and everything. Now, we didn't compare different kinds of coffee. I think somebody asked that at some point a couple of years ago when we first did this. But it was really impressive to see this take a fully occluded system in the worst case scenario. I mean, nobody's going to put a shunt into a patient who's got coffee ground level of cells and debris. But we took the worst possible case scenario and we demonstrated that the ReFlow actually does what it's supposed to do. So that was a huge sort of proof of concept point for us to be able to say, the chances of this thing working in a clinical setting, if it can work in this setting, is just it's got to be 100%. It's got to work to some degree. So that's where we sort of allowed ourselves to really go forward with implanting at that point, is once we felt confident with that sort of a test.
Well, so Dr. Eskandari, thank you so much. Thank you to the audience for the great questions. I'm sure that if people are hesitant to ask now, you can email them in and Mark and the team would take them. I have a last question, which is, can you inject coffee directly
into the brain? I think I think if we could figure that one out, coffee directly into the brain through your shunt, and you just wake right up. Right?
We would have a business model right there. No, so Anyways, thank you again, and I hope everyone has a great day.